So Anand, over to you.
Thank you, and it's a privilege to speak in front of an audience which does include Dr. Kaur. I've been asked to speak on advances in IOL calculation in post-refractive surgery patients. I guess the simple answer will be get an optical biometer, and that would be the end of my presentation. But to go deeper, I guess I would like to express my financial disclosure in Zeiss, Tommy Nidek, and the Lens Star, for which I have none, but it would be nice to have some. I guess getting accurate IOL power is like achieving nirvana, especially in these difficult cases. And since we have post Mahakum, it's a good idea to try and continue that feeling. Perfect cataract surgery is no longer utopian. Getting 6x6 vision in majority of the patients actually works quite well. Our promises are, we promise sutureless patients, sutureless surgery, painless surgery, less post-op recovery time, but we also have to make sure we want more, not less, for our own services. I'll start with one patient, 58-year-old lady in the business of government contracts, diagnosed to have cataract at another hospital, wants to read the Bible without glasses. Her children are doctors, son is a clinical trial specialist. He's done intensive research on the different types of IOLs and me. He's read my papers published, has a discussion on my PCR rates, number of premium IOL surgeries done, and son discusses the average post-op results, including the confidence intervals. The daughter wants to observe surgery, and she does come in for surgery. The patient's pre-op preparation included antibiotics and NSAIDs, and my pre-operative preparation included prayers to Vishnu, Shiva, and Jesus. And luckily for them and me, the surgery went off perfectly. Post-operatively, in a post-RK patient, we were lucky with good vision post-surgery in this patient with trifocals, and at the end of the day, the management was happy with the income, and I was happy with the outcome. Getting accurate power post-surgery, especially in these set of specific conditions like post-refractive surgery, keratoconus, ectasia, post-RK and post-keratoplasty are important, and it's important to know how well we really do in these situations. Getting good results in normal eyes, probably in more than now 80 to 90% of majority of patients. Some of the formulas even give us 92% in 0.5. But post-refractive surgery, keratoconus, and these specific set of patients do give some challenges. We do know about smile and lenticle extraction, which is probably now fairly commonly performed. You got smile and LASIK PRK, wherein the corneal surface is changed. But in RK, there is an intentional wound weakening, which does alter both the anterior and posterior surface, which is slightly different from LASIK or a PRK, where predominantly the anterior surface is altered. And this is important because we do know that the radial incisions flatten the central cornea. The central flattening with peripheral steepening causes the irregular astigmatism, fairly common. You do still see those post-RK patients, and the impact is basically significant K errors, which sometimes requires a historical data approach. Now, what are the fundamental challenges? You got an unpredictable the final lens position. You got unreliable K readings, which gives false corneal measurements. So in myopia, you tend to get wrong readings, in hyperopia as well. You got an altered corneal shape, and you are missing some historical data, which does affect the final outcome. The refractive surgery challenge is basically a standard IOL power calculation. You need to have predictable corneal curvature, you got to have regular aspheric shape, and it assumes a standard relationship between anterior and posterior curvature. While post-refractive, all this actually changes. The traditional K readings then becomes unreliable, and the effective lens position predictions also become challenging. There are, of course, multiple methods, historical and no history method. I would not touch upon the historical method because that's less commonly used, but we do still use the Barris-True-K, and there are, of course, some other formulas which can be helped to confirm your final K. Now, the double K method, which looks at pre-operative and the post-operative K, and then this is put into a Vergen's formula, and there is a formula adjustment which helps to improve the accuracy. When you look at IOL formula generations, we are now predominantly in the 4th and the 5th generation, and I know there are audience among us who have used the 1st and the 3rd as well. But now the level of accuracy, even with the 4th and 5th, in this specific group of post-refractive is still not that perfect. The important parameter is the direct corneal measurement. You have multiple methods, Scheimpflug, which was mentioned. You have OCT-based methods, ray tracing, probably the new kid on the block, and you have true net power, which some machines actually gives, which accounts both for the anterior and the posterior surfaces. When you look at recent publications, and this is one publication I could find in Indian eyes, the predictability of the ACRS online calculation versus the Barrett's True K, the predictability was maximum actually for the Barrett's True K and the Sharmas. So I think if you want to take one formula, at least in Indian eyes, a True K would be a good starting point. Now, the other important point is this is a meta-analysis, and wherein they looked at the accuracy for 0.5 and 1 diopter. And I feel if you have a normal eye, 0.5 probably makes sense. As eye surgeons, I feel we need to be kind to ourselves and accept that +1, -1 is a better range for these challenging eyes. And in majority of these specific formulas, it can vary between about 80% for majority of the present formulas that are being used. The meta-analysis does show that for a set of normal eyes, majority of them do better than 80%. But there is a difference between myopic and hyperopic corrections. Myopic accuracy is a lot better compared to hyperopic, and that's probably the way that the laser is ablated. When you look at optical biometer comparison, is there a difference? Well, most of them, at least in terms of axial length measurement, very, very close. In terms of the corneal, the spherical difference, not a lot. So any machine that you invest in these high-end machines would probably not really make a bigger difference, and I think all of them would be fine. And I have access to the Tommy and the IOL Master. I feel both of them actually do quite well. But there are some specific factors in the IOL Master, Lenstar, and the Anterion. Anterion and Argos has come in a lot more recently and tends to give better epithelial thickness mapping and has ray tracing capabilities, which probably gives a slight edge. In terms of foveal fixation, I know the IOL Master is probably the gold standard, the first one that actually started this revolution of biometry. In standard eyes, I think all of them are very, very good. Most of them actually do quite well. When you looked at formula comparisons for post-refractive patients, within about, most of them cross 70% for about 0.5. So I think in terms of the formula, if you have to measure it, the K measurement along with the axial length measurement would be critical. There are some strengths and limitations for a lot of them. The Barrett's True K is excellent for all refractive surgery types, but it is limited in extreme axial lengths. The Kane formula has some AI input, requires an internet cushion, and probably slightly less published than what has already been done. The Hages-L, probably good for myopic, less accurate for hyperopic and RK cases. Intraoperative aberrometry, probably the best available if you can get that, if you have access to the technology. It allows a final adjustment for lens rotation and exchange if needed. There are, of course, emerging technologies which are AI enhanced, but when we look at the word artificial intelligence, I think the artificial part is the machine, the intelligence part is still going to be the surgeon. There are some cloud-based calculators, there is some high-resolution OCT, and there is some talk of personal lens design like the LAL IOLs, which really does help. When you have a problem flowchart, which we use, you have to have a patient assessment, you collect the data, you look at the formula selection, you try and compare across multiple formulas, and if you have access multiple machines, and then you select the lens. You need to always give a 1 in 10 chance that you may not be in the perfect range. So key takeaways, you have multiple formulas, a good idea to cross-validate across 2 methods. You need to use modern technology. At present, probably OCT-based biometry is the most advanced, and you need to manage patient expectations. Thank you so much, Arup, for allowing me to be a part of the session.
Thanks a lot.